We're going to start talking about now is a little bit more of the physiologic changes we see acute wise at altitude now that we've kind of rehashed a little bit of what are the gas exchange mechanisms and kind of how Dalton's law and partial pressures fit into all that. So one of the things we're going to see that happens when you're at altitude, and again, this is not exercise or anything else like that. I mean, we can start figuring some of this in, but what we will see in the short term is you're going to see an increase in pulmonary ventilation. So that's going to go up right away. Again, at rest, at any submaximal level of output, you're going to have a high respiratory ventilation, a high respiratory rate, and a higher ventilation amount than you would have normally. At maximal exercise, again, you were kind of doing a maximal ventilation at that point, so you're not going to see a big change at maximal exercise. The other thing we're going to see is the part of the reason for this is that the lower concentration or partial pressure of O2 is going to stimulate those chemoreceptors. And what we should see overall is, at least for the next hours and few days until we start seeing some acclimation, is you are going to have increased tidal volume for hours to days. The other thing is the respiratory rate is going to be higher at altitude, so we are going to have hyperventilation. One of the things that this is going to do is it blows off more CO2. So in the short term, we have an issue with decreasing our alveolar levels of CO2 become lower, which means we get a bigger gradient, which means we have more CO2 loss. And what this does in the short term is gives us a respiratory alkalosis. We are going to start getting blood that is slightly alkaline, and this is going to bring in some other changes that we need to deal with. So the threshold for this to happen generally is about 10,000 feet. Again, that ventilation is going to be even more profound as we go higher up, but it's at about 3,000 meters or about 10,000 feet where we start seeing the first big issues with this. Like it says, initially, this is an increase in tidal volume to start out with, which will be then followed behind by an increase in frequency, both of which are increasing your overall ventilation, and again, is going to lead to dealing with these hypoxic conditions. Again, it can be even more profound if we get increased severity in these as you continue going up. So, and again, this increase is due in ventilation is due to either a drop in that inspired O2 or a drop in the arterial O2 below that threshold. This is going to try to increase our intake of alveolar O2, and it does end up causing us to lose more alveolar CO2, which is going to give us a bigger gradient in terms of losing that CO2, give us some alkalosis. The other thing this is going to do is by trying to ventilate more often, we are getting a bigger partial pressure gradient, an increase of that partial pressure gradient in the alveoli, which is going to give us a bigger downstream gradient to try to push more into the arteries. So increase that PaO2, that P little AO2, which is the arterial oxygen saturation, partial pressure of arterial oxygen, is what we're going to try to bring up by getting us a better exchange of gases at the alveoli, which will increase the partial pressure of oxygen at the alveoli, which gives us a bigger gradient to move it into the arteries. And again, this is being stimulated because of chemoreceptors picking this up in the carotid arteries, the aortic arch, in the medulla from the chemoreceptors in your cerebrospinal fluid, measuring that as well. That is going to stimulate this increase in ventilation due to hypoxia. And because of that Haldane effect, the higher O2 in the lungs, it's going to stimulate us to have more CO2 and release of hydrogen ions prior to acclimation from the breathing. Again, this is going to cause a little bit of an issue in terms of your breathing drive. That ventilation drive is going to be triggered a little bit by these drops in CO2, but it's being offset by the fact that we have low arterial oxygen. So again, it's our hypoxic receptors are kicking in and almost overriding some of those CO2 regulations due to the fact we're hyperventilating. Again, this respiratory alkalosis is this higher blood pH is going to come in. One of the things this does is it will cause a hemoglobin shift a little bit more, which is going to, like I said, it will left shift. That means that the oxygen is going to hold on a little bit better and not unload as CO2 as easily, which ideally will stop us from getting increasing hyperventilation. And the main way the body ends up dealing with this is at the kidneys. So we are going to start excreting more water to get rid of this bicarbonate ion. So actually urinating this out to get that pH back to normal. The one issue with this is it does require more water, so the hydration status needs to be good in order for this response to happen. Otherwise, you can start getting bigger issues with respiratory alkalosis or that blood pH getting too high. The other thing this is going to do is cause some drop in that overall plasma volume, which can be an issue as well. The decrease in that arterial CO2 and the increase in pH is also going to, like I said, it shifts that hemoglobin saturation curve to the left, which is going to increase the affinity of the hemoglobin for oxygen and honestly increase the affinity for oxygen on this one. So what this is going to mean is we're not going to unload as much to the tissues, which if you start thinking about what's going on there, that does start to become an issue if you're trying to be active at altitude. So again, we have a number of things working against us if you start trying to do any type of activity at altitude. But this left shift is going to mean less oxygen delivery to the muscles now that we're at altitude, because the hemoglobin is going to hold on to it more forcefully because of that left shift due to changes in pH. So the diffusion at the lungs, at rest, this is not limiting gas exchange. We're still having enough of a gradient that there is still gas exchange here, and where you're going to get that alveolar PO2 still being able to reach equilibrium with the capillaries. But again, overall, that lower alveolar PO2 is going to give us less of a gradient. As we start going high enough, though, what we're going to start having an issue with is you get low enough, decreasing alveolar partial pressures of oxygen sooner or later are going to stop allowing us to fully saturate our hemoglobin. So we start getting decreases in hemoglobin saturation. And again, that left shift also was not going to help with this. So we can kind of see at normal sea level, our arterial blood is going to have a much higher level of partial pressure of gas here. You can see when you start looking at here, we are still going to come close to reaching equilibrium with the alveoli, with what's in there, but again, because it's such a lower partial pressure, there is less oxygen to be delivered to the tissues. So we have a much smaller gradient. This is not going to move as well or as quickly. Again, anything that is dependent upon this oxygen is now going to be affected, and we're going to have decreases in performance due to this. And again, this is just showing those saturations and that left shift. So that left shift is the blue line, where you can see it starts holding on to that at higher levels. Again, this starts to become an issue at the muscles when we start talking about delivering this. We might be able to come close to saturating this at certain levels here, but if we're holding on more tightly to oxygen, what this is going to mean is normally, as I was shown on that one figure, we have a gradient of about 60 millimeters of mercury. When we get up to, that's going to be 4,000 meters, it's going to be about 12, 13,000 feet, we only have a gradient of 15 millimeters of mercury. What this is going to mean is that diffusion to the muscles is going to be greatly reduced at that altitude. And again, at the lungs is not as big a deal. The fact that these hemoglobin isn't saturated at the lungs. We're still going to pick up oxygen. The main problem this becomes an issue with is that lower gradient at the muscles means we cannot deliver as much oxygen to the muscles. And if you're talking about any type of activity, it means you're going to have reduced work capacity due to less oxygen. So again, if we were looking at our VO2 max, it is going to have dropped when we get to this level of altitude. And this is kind of showing you a time course to become to get the equilibrium with alveolar, partial pressure of oxygen in the pulmonary capillary. And really what this is just kind of showing is at normal levels, we can reach equilibrium rather quickly. You can see as we start getting less oxygen in the alveoli, it's going to take longer time to reach equilibrium because there's not as big of gradient. So again, what it's saying over on the right here, as we get increases in altitude, that diffusion time becomes longer because there's a lower gradient. It takes longer for it to move into that bloodstream. And again, means lower levels, and again, lower levels when we get to the tissues means less oxygen getting to the tissues. We are going to be dilating these vessels a lot of times to increase this as much as we can. Training increases that pulmonary diffusion capacity because we've increased our capillarization, so this can help out with this. And also the fact that we have increased plasma volume and higher hemoglobin will all help with this altitude. But again, you get high enough, you're going to not be able to deliver as much oxygen to the muscles, which is going to decrease your ability to do any type of work. Like I said, in the short term, because we are having to urinate a lot of this respiratory alkalosis, and because the air is drier, we're also losing more water to the environment as well. We are going to have decreases in plasma volumes within a few hours. We're going to lose up to about 25% of our plasma volume. So short term, like it says there, decrease in hematocrit and oxygen density in the blood. But again, we have less plasma volume, less ability to dilate this, less ability to deliver this blood to other areas because we do not have as much of it. What we're going to see is one of the things that's going to happen over time is we're going to get increases in red blood cell count due to EPO over time and increase red blood cell production over time, which will give us that longer term increase in hematocrit with a higher plasma volume. But in the short term, our higher hematocrit is just due to less water. We're concentrating the blood, not putting more red blood cells into blood that we're not just putting more blood cells into a normal blood volume. We're actually losing blood volume, and that causes that hemoconcentration in the short term. Long term, we will get that plasma volume back after acclimation and have increases in red blood cell counts to help try to make up for this. Because we have this loss in plasma volume, that means at any particular level of output, except for maximal, cardiac output is going to go up because we have less blood to go around. So to give a certain amount of output to the tissues to do work, cardiac output has to go up. So we're going to get increases in heart rate and stroke, really increases in heart rate to make up for less plasma volume and a lower stroke volume. So at rest, as well as submaximal, we're going to have increased heart rates. Again, this is a short-term adaptation to deal with the fact that we cannot deliver as much oxygen because we don't have as much blood and we don't have as much oxygen in reality. So this is a short-term increase of the sympathetic nervous system to increase that heart rate, to increase cardiac output, to deal with this in the short term. Again, this is something we can only maintain for a little while. What we're going to see is after a few days, we are going to start seeing some changes where we are able to, and we'll start getting into this, where we're able to start extracting more O2 from that blood. We're going to start getting some changes in the metabolism and those hemoglobin saturation curves that are going to start helping us out. This will decrease that dependence on cardiac output after those first 6 to 10 days, and we will start making up this difference a different way. But the short term, you're going to see increasing heart rates at altitude to deal with that lack of oxygen and the loss of plasma volume. So again, short-term responses here, we have a decrease in cardiac output because we have a decrease in stroke volume, that heart rate max because we don't have as much oxygen available to us. The heart is not able to work as hard. Stroke volume is decreased because plasma volume, the sympathetic nervous system responsiveness is decreased. The other thing is we have a decrease in that O2 gradient because we have a decrease in output, cardiac output, which means even just based on the heart stuff, we're going to have a decrease in VO2 max. So again, at altitude, especially in the acute version here, there's going to be a decrease in performance at any level of output. The other thing we'll see is our metabolic rate is going to be increasing. We're going to have increased releases of things like epinephrine, norepinephrine, thyroxine to increase this. What becomes an issue is we need to bring in food to maintain this. One of the tough things is you need oxygen a lot of times to break down food, and if you're at high enough altitudes, the amount of oxygen necessary to break down this food is limiting, and you really start having issues with taking in enough food and breaking it down to even maintain the body mass and this increased metabolic rate. The other thing it means is because we're low on oxygen, we start depending upon things like glycogen and glucose a lot more than fats, and anaerobic and increasing lactic acid production. In the short term, over time, this will drop, and there's not a good explanation as to why that happens entirely, but increased anaerobic metabolism in the short term, increased lactic acid buildup. So this again kind of takes you through all these stuff in the first 48 hours here. So we're talking about increases in ventilation. You have less of that 2,3 DPG by the cell, by the tissues releasing this. Our hemoglobin starts holding on to oxygen more. We have respiratory alkalosis. This leads us to having increased ventilation. Cardiovascular wise, we have less plasma volume, which means an increased heart rate, less stroke volume. We're trying to increase our cardiac output to make up for that. We have to have a higher blood pressure to deal with this. So at any level of exercise here, it means higher heart rates, more cardiac drift. We're going to have a decrease in our overall VO2. Metabolic-wise, we're having increases in metabolic rates, which means the effect on us is that we're using more carbohydrates. And then finally, renally, we are having much more urine formation to get rid of those bicarbonate ions, which is part of the reason we have that decrease in plasma volume. So this is, again, just giving us some of these short-term changes that happen when we're trying to do something at altitude. We're also going to start trying to talk about being active at altitude, which you're going to see that starts becoming very difficult. But when people start talking about going and doing mountain races, for example, what are some of the issues that come along with that? Again, because we are having to produce more urine, dehydration, we are losing more through the air because there's less in the air. So breathing, we're losing more. We're having to form more urine to get rid of this. If we do any type of exercise and sweating, this is going to do it even more. So in order to really make up for this, we have to consume a lot amount of water. Again, at altitude, we are having issues breaking down food fast enough, so you get a decreases in appetite even though you're having increased metabolism. So you generally start having calorie deficits every day. And again, if you're at high enough altitude, it can be difficult to take in enough calories to maintain this level of metabolism. The other thing is as we start making more red blood cells, the iron intake needs to be high enough to start being able to maintain the necessary levels of iron to manufacture more hemoglobin. So that is our first little one here. This gets us through the first two shows here. So this is going to be kind of our next week of stuff here. We'll start then looking now at altitude and exercise. And then finally we'll go into adaptations about this. So again, this stuff for altitude should take us a couple of weeks. So I will talk to you next time.